Hi, my name is Dr. Bailey Terhune from Midwest Orthopedics at Rush, here to talk to you about our JBJS study entitled A Novel Fluoroscopic View for Improved Assessment of the Safety of the Posterior Superior Screw in Femoral Neck Fracture Fixation. Femoral neck fractures are often treated using cannulated screws in an inverted triangle configuration. However, the safety of, in particular, the posterior superior screw has recently been called into question. There's studies that show that about 2/3 of these screws, which appear radiographically safe on intraoperative fluoro, are actually partially extraosseous or in-out-in. Why does this cortical breach matter? The posterior superior cortex in femoral neck fractures is integral for mechanical stability of the fracture, and a disrupted cortex is a risk factor for late fracture displacement. So ultimately, we need a better way to assess screw safety intraoperatively in these cases. The purpose of our study was to determine the specific fluoroscopic views that most accurately evaluate placement of the posterior superior screw in femoral neck fracture fixation. Our hypothesis was that the standard PA and lateral views would falsely identify screws as safe, when in reality they were in-out-in or partially extraosseous. There were two phases to our study. In phase 1, a single 3.2 millimeter guide pin was placed through the posterior superior aspect of the femoral neck using synthetic femur models. The guide pin was placed either entirely intraosseous or in-out-in. Then sequential fluoro images were taken at 5-degree intervals to determine which X-ray projection best identified this in-out-in guide wire placement. In phase 2 of our study, we evaluated these fluoroscopic views using 10 cadaver specimens. The 7.3 millimeter partially threaded cannulated screw was placed into the posterior superior aspect of the femoral neck using standard operative technique, which combined a PA fluoroscopic view and lateral view. Once the screw was deemed safe based on these images, the position was not moved and the screw was evaluated on all of the fluoroscopic views determined from phase 1. The fluoro shots were then randomized and blinded for review by orthopedic residents and fellowship-trained traumatologists. Finally, the specimens were dissected free of soft tissue to evaluate visually for cortical breach. After soft tissue stripping, we found that 4 of the 10 screws were in-out-in. All of these screws had appeared safely contained within bone based on the standard PA and neck shaft lateral views. In conclusion, our study showed that the standard PA and 0-degree neck shaft lateral views provide an inaccurate assessment of the posterior superior screw placement and often portray that the screw is safe when it is in fact in-out-in. Our data shows that the addition of just one single minus 15-degree roll under view can greatly improve identification of in-out-in cortical breach of this screw. This view can easily be added to your intraoperative sequence with minimal impact on surgical workflow and potential significant benefits to patients.